Good morning.
A lot of fun to like see that group.
My name is Bob Goodholm. I'm one of the co-chairs. Janelle Headings and I are co-chairs for the psychosocial research showcase. We culled through a lot of really excellent research to get to this. So I think you're in for a real treat. Your coffee has come in. It's early morning, so we're going to get started. This is a disclaimer. These are just the things, censors. We don't have any disclosures except for that we get a little help with the trip. These are the sessions. We asked that you hold your questions until the very end. Each presenter is going to get about 15 minutes to do their research, and then at the very end, give you a chance to ask any questions. Our session goals today are to identify common impactful mental health comorbidities in adults with cystic fibrosis. We're going to examine cannabis use and self-reported symptoms in people with CF, identify male sexual and reproductive health topics and outcomes identified as important within the CF community. We're going to discuss current suicide assessment data in U.S. CF centers and identify key mental health variables for inclusion in the next large update of the CF Foundation registry. And we're also going to review the effects and adjusted ETI dosing on sleep, behavior, and physical symptoms in children. So the very first abstract, we're going to ask Dr. Whitaker to come up and just try to do it briefly. She doesn't use this. Dr. Quittner is a senior scientist at Joe DiMaggio Cystic Fibrosis Pulmonary and Sleep Center and has published over 230 articles and book chapters. She received this Richard C. Clinical Research Award from the CF Foundation in 2008 in recognition of her development of the first health-related quality of life measures for cystic fibrosis, the CFTR, which are now used worldwide in trials. In 2016, she was awarded the CF Foundation Richard Mack Award in Mental Health Care for her international epidemiological study of depression and anxiety in patients and caregivers. She's now co-leading a national dissemination and implementation effort to translate mental health screening into clinical care, as well as several clinical research grants funded by the CF Foundation, including the development of the GEMS CF screener and launching the TIDES 2.0 study for children under the age of 12. She's leading a national effort to assess professional quality of life and burnout in CF health providers. And she currently chairs the research subcommittee of the CF Foundation's mental health advisory.
I want to thank the Program Planning Committee and the session chairs for inviting me to present on the development of the General Mental Health Screener for CF, GEMS for CF. I would like to start by acknowledging and deeply thanking my research partner on this project, Dr. Beth Smith. I don't think around for her, not sure. We have worked on this project together, developing this screener. Beth and I conducted all 16-minute qualitative interviews. We also helped to quote the transcripts with our amazing research team, Dr. Georgiopoulos, Robin Wade, Tara Mullen, and Nivi Chowdhury. And we've just completed the cognitive testing of 22 adults with CF. We heard heartbreaking stories of severe anxiety related to pig lungs, blood clot, traumatic stress. We heard about challenges with insomnia or quality sleep, ADHD symptoms, and challenges with body function. And we would like to share their voices today. These are disclosures. So this research really came out of the CF Foundation Research Prioritization Workshop. They launched a very major survey in 2020. You can see here we had 609 respondents from the community, 352 CF providers, and you can see on the right side those priorities. And a large percentage of the community endorsed the importance of assessing additional comorbidities aside from depression and generalized anxiety. Comorbidities such as body substance misuse, ADHD, medical traumatic stress, and also side effects of immersions on mental health, which of course in this era of Trikafta, this is extremely relevant. So I wanted to show you these very small single center studies that hint that we have a higher prevalence of these comorbidities among adults with CF than the general population. Disordered eating and body image, 24% in CF populations versus 9% in the general population. 24% of adults with CF reporting heavy alcohol use, 49% binge drinking versus 25% in the general population. Painful medical procedures, 93% of adolescents reporting needle-related distress and 76% exposure to medical trauma. And executive function, we think ADHD is more common, perhaps 3 times as common in adults with CF, 15 to 19% versus the community of 4 to 5%. So these small studies indicate that we do have a high prevalence of these comorbidities, and we need to pay attention to them. This is a lovely study, part of our Leadership and Design grant with Dr. Georgiopoulos, and we surveyed 100 CF centers across the United States, asking them whether they're screening for any other mental health conditions. You can see only 16 out of 100 centers were asking about these other comorbidities. And if you go down that list, ADHD, only 5 centers asking about it. And down at the bottom, substance misuse, only 8 centers. So there's a great need here to assess. Our conceptual framework comes from the FDA guidance on patient-reported outcomes, where the heart of developing an instrument is to go to the patients themselves, listen to their voices, and elicit the concepts and constructs that are important to them. If you look at this measurement wheel starting at the top, I'm going to do this very briefly. Our first goal is to identify the concepts and domains that are relevant to these patients. Next, we use the transcripts, we listen to their language, and we create items that reflect their challenges. We chose the recall period, the way that we're rating the frequency and feasibility and impact of these comorbidities, and finally doing psychometric validation, reliability, validity, et cetera. And it's an iterative process. We also adhered strictly to the COSMIN measurement standards, and COSMIN stands for Consensus-Based Standards for the Selection of Health Measurement Instruments. And I just pulled up one example here. We have gotten a rating of 4, very good on all of these dimensions, and it goes from inadequate to very good. So I just pulled out content validity. Was an appropriate method used to ask patients whether each item is relevant for their experience? And Beth, who just watched, she actually did the cognitive testing with me. We asked people specifically, is this relevant? Is it clear? Are we missing anything? So we really met all of the guidelines in COSMIN. These are our phases of instrument development, beginning with concept elicitation, qualitative interviews, on to cognitive testing with a new sample of adults with CF, not those who generated the content. And then we are about to, when we leave NACFC, launch the 3rd phase, which is a preliminary psychometric validation, getting at reliability, validity, sensitivity. So our aims: to conduct a mixed method study, assessment of mental health concerns in adults with CF. We began with qualitative interviews. Really, these interviews were heartbreaking, and even coding them with our research team. The trauma that we experienced, the secondary traumatic stress, was really significant. We also conducted 2 focus groups with 19 CF healthcare providers. So aim 2 was based on the frequency and impact of what was elicited in the first phase to develop a brief screening tool, less than 25 items. We also assessed modulator-associated symptoms, and Dr. Smith will be presenting a talk on that on Friday in the ETI symposium. We assessed the feasibility, acceptability, and helpfulness of this potential new screener. And then, as I mentioned, we will be going back to our original 60 adults with CF to have them now look at the screener developed based on their input and rate it, and then rate some convergent validity measures. We are very proud of the sample that we recruited. We purposely sampled a very diverse group using many different techniques. This is one of the most diverse samples I have ever seen published in CF. We went to all of these resources out in the community, and I have to say, Dr. Smith and Dr. Georgiopoulos even attended the CF Senior Saturday group. And we have lots of seniors in our sample. One of the most successful techniques we used was called snowballing. So if we found a diverse minority or diverse person with CF, we asked them, do you have friends or colleagues or peers you might pass this on to who might be interested? That actually helped us tremendously in increasing the diversity of our sample. So we are very proud of this sample. If you start on the right side, you will see we have the full age range very evenly distributed from 18 all the way to 74. We are not leaving out older people with CF in this study. If you look at gender, we have 30 men and 30 women. We were very happy to balance that. Race and ethnicity, 12% Black, 8% Hispanic, and 15% other, including a French-Canadian Inuit. Modulator status. We had 63% on modulators, but interestingly, 5% had discontinued due to side effects, and 2% for other reasons. One person's family did not approve of the idea of a lifelong medication. And finally, poverty. We really represented 30% were low SES, below the US federal poverty level, and 27% LGBTQ+. We're very proud of this. Here are the results of AIM-1. The most important takeaway from this is this top graph. On average, people endorse more than 6 of these comorbidities in the top 10, more than 6. We also, if you look below the PHQ-4, we used a priming technique. To first screen, Beth and I would screen with the PHQ-4 to let them report symptoms of depression and anxiety so that they could then shift their focus to other comorbidities aside from those. And you can see 33% of our sample was reporting moderate to severe depression and anxiety. They rated this 85% as very feasible and 82% as very helpful. Here are our top themes, ranked ordered by frequency. This is incredible. 90% of our sample reported procedural anxiety and 90% disrupted sleep. 85% negative body image, 80% trauma and PTSD, including 38 people who reported medical traumatic stress, 25 physical, sexual, or emotional abuse. Attention deficit, 73%. Modulator side effects, which I mentioned Dr. Smith will present tomorrow, 67%. Lifetime suicidal ideation or attempts, 38%. Disordered eating, you can see the numbers. So really prevalent. I'm just briefly showing this, and I've listed Dr. Smith's presentation tomorrow. But here are the modulator symptoms in 45. Uncertainty about the future, body image, brain fog. I think we all are very aware of these modulator-associated symptoms. Insomnia, GI, anxiety, pain, mood swings, inattention, and eating challenges. So now I would like to really read to you some of the quotes that we got from these interviews. Every time I'm going to have that procedure, drawing blood, I feel scared, especially in the morning. I feel like I don't want to wake up. I usually cannot sleep without a sleeping pill. Now it's my thoughts that keep me awake and stop me from sleeping. Sleep has been really difficult. In the gay community, I think there's a big emphasis on physical beauty, having a particular body type. I always just felt I didn't have much of a body, or I was embarrassed to be that thin. My torso is basically a roadmap of surgical scars, so I never take my shirt off in public and rarely around my wife. Because you're disabled, you're a prime target for abuse because you become so financially dependent and security dependent on a place to live. I was sexually molested in the hospital by a male nurse after I woke up from transplant. I've had ADHD my entire life. Doing work is difficult because I could sit down and when I try to read a book, my mind just goes elsewhere. That makes college especially difficult. So those were the kinds of stories we heard. And in the next phase, cognitive testing, we just completed that with 22 people. One person had unusable data. We tried to, again, retain that diversity. So you can see, again, 22 people. We have male, female, non-binary. We have 14% Black, 14% other, 64% on modulators, and 23% LGBTQ+. So this is our initial draft of the screener. You'll see it's 28 items. I just want to tell you that since these are not necessarily events that happen every day or within a 2-week recall, We decided to ask it more in exposure. Have you ever experienced these concerns? Yes or no? If you say no, you don't go on to complete how often or how impactful. Only if you say yes do you then rate the frequency, never, sometimes, often, very often, and the impact, not at all, a little, some, a lot. People thought the rating scales were very easy, simple, the instructions were clear. We got very positive feedback in our cognitive testing. So now, here are our revisions. We changed waking up during the night to having poor quality sleep. People preferred the term feeling anxious about doing PFTs. They didn't like lung function. People preferred universally experiencing feelings of grief rather than loss. Have you experienced stressful life events rather than asking directly about abuse? Feeling restless rather than restless and fidgety? Feeling more irritable rather than easily angered? And using cannabis to help cope with my CF rather than using marijuana, and similar for alcohol, using alcohol to cope. So this is how we have deleted items that didn't work in the cognitive testing. This is the iterative process I've been explaining to you to come up with this final version of our screener. 24 items. We are now going to put it back out into the field to do a preliminary psychometric validation. We likely will cut more items. We may get down to just 20. This should be less than 5 minutes and very brief. I want to show you on the right side, this is how we see it being integrated into our current screening program. That the PH29 GAD7, we know 95% of centers are screening at least annually, and we would add this 5-minute GEM-CF to the screening protocol at least once a year. Our results suggest that mental health comorbidities are highly prevalent. Strategies to recruit a very diverse sample were highly successful. We're very proud of this sample and think it really represents the CF community. The feasibility was rated as very feasible of using the screener and potentially very helpful. And our next steps are preliminary validation. And we just put in our grant to do a national psychometric validation with 250 adults with CF. So see what happens with that. So I have a huge thank you to the GEM-CF research team. All of those people have worked incredibly hard. I want to call out our research community partners, Dr. Ed Kanda, Dr. Zan Nowakowski, and Laura Tillman. These 3 community members have helped us at every single phase of development, have given us feedback, comments, have changed things in the way that we write our items. They have contributed enormously. And finally, of course, thank the adults with CF who were willing to participate in our study. Thank you.
As a reminder, please submit your questions through the NACFC app, and we'll get to them at the end. Thanks.
All right, our next speaker is Dr. Carla Frederick. Dr. Frederick's clinical practice focuses on the management of general pulmonary disease with a specialized interest in cystic fibrosis and bronchiectasis. As a physician consultant for the inpatient pulmonary consult services at Buffalo General Medical Center and at Roswell Park Cancer Institute, she attends to the needs of hospitalized patients with pulmonary problems in conjunction with the University of Buffalo's Physicians Group's pulmonary team. She is a dedicated supervisor and mentor to a team of talented fellows, residents, and medical students. As the director of the Adult Cystic Fibrosis Center in Buffalo, she provides comprehensive care for individuals with cystic fibrosis, as well as local care for patients who have received lung transplants for CF, coordinating and collaborating on their care with the transplant physicians and healthcare providers. Dr. Frederick is actively engaged in clinical research through many international clinical trials, and through this work strives for improved therapies and a cure for individuals with CF.
Thanks.
I don't know who wrote these bios, but I didn't. It was a lot. All right, this is the mandatory disclaimer. And I have no disclosures related to this presentation, except you'll note that I am a pulmonologist. I'm not a psychologist, and I don't have any expertise in cannabis, professionally or socially. So I'll try today to just give you an outline. Oh, and another disclosure I should say is this is not my data. So I so graciously landed on this because I was fishing around with Dr. Reichert, with whom I work for the STRC, and some of our information was not available for presentation yet. And she said, I think I could quote her and she won't be too mad. You like substance, right? And I'm like, okay, yeah, I kind of do. So this data landed in my hands in that way, and I'm happy to present it. So I'll go through some terminology of cannabis marijuana, which I thought was interesting, was changed in that GEMS survey by the patient representatives, the legality. I'll talk briefly about the existing data, bring it back to CF, like why we care about it, talk about the survey format, and then just go through some conclusions, implications, and such. So, mandatory picture of a cannabis plant, if you have a cannabis talk. Cannabis versus marijuana. So the terms are used interchangeably. They do refer to the same plant and the chemical compounds derived from it. If we go to THC specifically, that's the main intoxicating component of cannabis, but it's shown to have analgesic and anemetic properties. CBD is the constituent that is traditionally thought to be non-intoxicating and non-psychoactive, and it may have anxiolytic properties. The variability of how these affect an individual are obviously widespread. So the legality. This is governed by state medical cannabis laws. 47 states have some form of legalized cannabis use, and I left this blank for a moment so you could guess if your state's one of them that doesn't. The exceptions are Kansas, Idaho, and Nebraska, but there is a ballot initiative in Nebraska this year for that. There you go. Fun facts. Talk about it at lunch. California, if you were wondering what the first state was, therapeutically introduced this in 1996 for mainly HIV/AIDS epidemic in that area in that time. So medical cannabis use is operationalized differently by states. I guess similarly, not really, that as newborn screens can decide how they do it, states can decide how and in what way they will allow cannabis to be used. The specific ratio of THC to CBD can be dictated by the states. How much or what kind of training the healthcare practitioners have to recommend it is regulated by the state, and also what relationship you have with the provider has with the patient to recommend it. Legalized adult use is an evolving topic. This slide might be out of date, even though I updated it like an hour ago. 27 states have decriminalized the use of cannabis, and 3 states this year actually have a ballot initiative regarding its recreational use. And it's interesting what other substances have recreational use on the horizon, not just cannabis. So I learned a lot there as well. Medical cannabis from the federal perspective, however, is still a Schedule I status drug. It's prohibited, and so it's not prescribed, it is recommended. So the dose and usage administration, guidance, and risks and benefits is on the onus of the provider who's recommending, though it's not prescribed as we would ETI or something else. So this is just a map that came from that website that I referenced earlier, showing areas that have no cannabis access, some that have recreational and medical use in green. There's no blue ones, so I'm not sure whether they have blue on the legend there, but then the other yellow and orange have different access in the medical realm. And is pertinent to this presentation, the recruitment sites for the study on which I'll present were both states that are green, so have both adult and recreational use available. So the existing data is not a lot, and I did PubMed search by cystic fibrosis and cannabis, or marijuana and cannabis, and even though cannabis is thought to be like the fancier term used by medical professionals, there's actually more published data on marijuana than cannabis, and 17 results came up. So I will not go through all of them, but some of them I thought they were interesting are here. And of course, as like a pulmonologist science nerd, I will bring you all to our realm. And this one just like struck me right off the bat. So in 2018, this showed that the psychoactive substance THC negatively regulated CFTR in the airway cells. So I'll just orient you to the slide because then you'll know what's happening in like the plenary. So this shows that the same amount of stuff was put in each of the gels. And then this shows that as you go in increasing intensity or concentration of cannabis, there's less CFTR that shows up. And that's really all you need to know when you see those kinds of slides. But I thought that was pretty intriguing, to say the least. So some of the other studies that I saw that were interesting just to highlight. One was a survey study done in 2020 just of the use of medical marijuana in cystic fibrosis patients. And what they sent out a survey to 6 centers anonymously, and they saw that it was about the same in adults with CF and without. This was another one in 2023 that came out basically looking at perceptions of cannabis marijuana in individuals. And the main takeaway from that study that I noted with that was there was less of a risk perceived with marijuana than combustible cigarettes. And that was associated with increased use and just a general decreased, what we'd say, appropriateness of education given how widespread it is. And then a couple of other clinician survey studies were out there. One just did a widespread survey of like, how do you assess? What do you do? How educated you are? And there's just a variety of different ways that people have approached cannabis and how they do or do not address it in a clinical setting. And then this other one that has a cool title, Clearing Up the Smoke, looked at some considerations, like trying to provide some education for us in our addressing this topic in conversation. But all the recommendations had the word possibly or potentially, because it's all extrapolated from data outside of CF. Time to be blunt, another cooler title than my title that was presented last year, showed over a 12-month time period, a survey of individuals and their use of marijuana, which recent users is in the yellow, was 29%, CBD was 22%, and e-cigarettes was 26%. And then the frequency is over here on this graph, which shows daily or almost daily of marijuana or CBD was 23% and 16% respectively. So it's out there, and that's what we see. So bringing it back to CF, we know CF, there's lots of therapies prescribed. In the ETI era, things are even different. And it's led to improved health outcomes in many people with CF. But some people still have respiratory symptoms that remain burdensome, and some, as Alexandra had noted, too, have many other comorbidities, mental health disorders, sleep disturbance, pain, fatigue that are prevalent. And, reaching the jackpot of ETI is not the jackpot for everyone, and there's other things that are still there. And as such, some pulmonologists like me might, not assess these things as we should. And so people might be left to self-treat. And there's been an increasing interest in cannabis in people with CF. And so this survey, what I've pulled out of this larger survey just looks at cannabis use and patient-reported symptoms. And so the survey was done between 2021 and 22. The eligibility were to CF, adult. If you're on modulator therapy, be there long enough so that it's stabilized, and similarly for psychiatric medications as well. Non-pregnant, we know that can really mess with you. No antibiotics in the last couple of weeks because that would likely indicate an exacerbation, and this was an English-speaking study. The measures were sent via REDCap and completed at home, so not under the eye of a provider in your clinic. And the measures that were seen in there that we'll highlight today were the sleep quality index, a fatigue severity scale, PHQ-8, GAD-7, pain intensity, and then a respiratory symptom diary. And so this is just a look at what the question would have looked like facing the patient or the person taking the survey. So have you ingested or swallowed, inhaled cannabinoid, CBD, THC, marijuana, or similar product in the past 7 days? No topical use was allowed. And so you are allowed to select all that apply for the reasons of doing so, and then the frequency. And so you can see from this question that there are not pens, dabs, drips, all the things that I've learned over the last several weeks specified here in the study. 363 approached, 236 ended up becoming eligible. From the demographics that you see over here, it's equal male-female, 36, so an average age of an adult. Something else I was going to highlight here, modulator use is about similar to the general population, maybe a little higher. And then this was actually kind of something that I didn't sort through until later. Many of them take medication for mental health. Many took pain. I don't know if this is Tylenol for a headache last week or something else. And many take something for sleep in the last week. So that's something else. And also the talk therapy is probably a little higher than the general population, I would say. So the results that we see, so this is bringing us back to the time to be blunt here, was that of the people completing the survey, 25% reported using cannabis in the last 7 days, and 34% for 4 out of 7 days. And that kind of went in parallel with that data that we saw last year with 23% using almost daily and 39% using about once a week. And the reasons are likely not surprising. So to relax, sleep, recreation, anxiety, pain, appetite, and nausea. And we'd say that I kind of divide these out into sleep being like sleep, anxiety, pain, appetite, and nausea being a symptom that they're treating, and then relax or recreation being something just purely recreational. So of the users, 19% use it only for relaxation or recreation. And 21% used it for one of those symptoms that I mentioned only, and then 60% used it for both. So one of those symptoms and to relax or for recreation. People who used it for symptoms, and I'll show a table in a moment that'll make this probably a little more clear, symptoms and recreation or relaxation reported more symptoms on those measures that I mentioned before, and higher scores or positive screens on PROs. Qualitatively, the people that only used it for recreation or didn't use it had lower scores on those PROs overall. So this can kind of orient you to that. So on the left, you see all those scores here that we mentioned for respiratory symptoms, they mentioned for, measured for sleep quality, fatigue, depression, anxiety, and pain. And so what we see here is the people with no use or using it for only recreation or relaxation had lower scores down the board than people that used it for symptoms alone or for symptoms and recreation and relaxation. Also, if you look at the folks that did screen positive, so if they crossed the threshold of screen positive for sleep disturbance, fatigue, depression, anxiety, or pain, you'll see in the dark blue tab here, sleep actually had a lot of folks that screened positive for sleep disturbance, use, not use, reason for use, irrespective, though the people that used it for symptom management and and recreation were much higher than those who didn't use or used it for recreation alone. Same you see in fatigue as well, and in depression and anxiety. Not as big of a signal over here in pain. So what do we make of these data? And there's a poster, this isn't a poster, I can't remember what number, but you can find that poster over, I'll let you know later. What it reported thought to me, or as I looked at this and we looked at it and talked, is that the cannabis use is probably not one of those ones that's under a state medical regulated recommendation. It did seem to follow more of a signal of self-treatment. Fine. So we know and kind of reaffirmed that we know that people with CF who self-treat their symptoms have comorbidities, and they're highlighted by all those higher scores on the patient-reported outcomes. But I know you can't say this is causal. So you can't tell, this is one point in time survey, and so we cannot tell if the relationship between these cannabis and comorbidities is causal or anything. We can't tell if the scores were higher and then they use cannabis and they are lower, or if they're higher because they use cannabis use. It is an association that we can do something with in the future. But it can serve as a reminder, if somebody's using cannabis use, hey, maybe I need to ask about mental health, though we are all screening, but perhaps dig a little deeper than their PHQ-9 GAD700, really? Or sleep, or fatigue, or pain, and determine if something more effective exists beyond our looking at our BMIs and our FEV1s and things like that. Limitations are many. This survey was conducted in a state where the cannabis use was either fully legal or legal for medical use, and as such, these findings might not be able to be generalized to states or countries where cannabis is not legal in any form. The form and amount is not specified, so I cannot tell you if they vaped, if they did all the different things that I know a lot more about than I did 2 months ago. This, again, cross-sectional study cannot assess any symptom change here. And this survey, like all the studies like in the last 5 years in psychosocial, it was around COVID. Who knows, right? There's all sorts of things that could have had other psychosocial implications at that time. What I took away from it is that more research is definitely needed to determine what people are using and how they're using it and why they're using it and for what medical comorbidities they're using it. Specific research directed at cannabis might be more feasible if cannabis use is legalized. And so there's not implications, or I'm afraid I'm going to get like locked up or something like that. Or the providers as well may have less hesitancy to conduct that kind of research. Symptoms besides those related to traditional markers of CF warrant routine assessment in the clinical setting, especially in this era of highly effective modulator therapy. And understanding what other substances people use, such as cannabis, for people with CF might help just illuminate other medical diagnoses and comorbidities that we don't know about and help facilitate more conversation. I'd just like to acknowledge Dr. Reichert and her team at Hopkins, Dr. Goss, and these are some of the articles I referred to. Thank you.
It's poster 548, cannabis use in people with cystic fibrosis. Thank you.
Okay. The next presentation is on male sexual and reproductive health and cystic fibrosis, a concept mapping study. Kelly Prangley is a clinical research coordinator at the University of Pittsburgh. Oh.
Sorry, it's for my shortness.
That's okay. I don't even think I'm tall, but okay.
More than 5.
Better. Kelly Prangley is a clinical research coordinator at the University of Pittsburgh School of Medicine and the Department of Pediatrics at the Division of Adolescent and Young Adult Medicine. They are a sexual and reproductive health researcher at the Center for Innovative Research on Gender Health Equity, and their research focuses on the improvement and comprehensive healthcare outcomes and access for adolescents and young adults with pediatric onset chronic disease. As a member of the Komersky Lab, their current research centers on improving the sexual and reproductive healthcare needs of people with CF, better understanding the impact of parenthood on those with CF, and exploring the knowledge, perspectives, and practices surrounding the unique healthcare delivery of LGBTQIA+ people with CF. Thank you.
Is that okay? Everyone can hear me? All right, hi everyone. I'm happy to be here. I'm going to be speaking about male sexual and reproductive health and cystic fibrosis, and I'm going to be sharing the results of our concept mapping study. These are my disclosures. I have no relationships to disclose related to this presentation. So to give you a little bit of background information as to why this study is important, we know that cystic fibrosis has a profound impact on male sexual and reproductive health. Nearly all males with CF are infertile due to congenital bilateral absence of the vas deferens. In addition to infertility, many males with CF experience issues with sexual functioning, including testosterone deficiency, erectile dysfunction, and low volume ejaculate. We also know that prior research has identified major gaps in SRH counseling and care for males with CF. Our team completed a national cross-sectional study of males with CF in which we assessed SRH care utilization, experiences, and knowledge. Here you can see some statistics on some of the SRH services that have ever been received by males with CF. As you read down the list, I'll let you do that yourself. You'll notice that a lot of these are below 50%. Some are even below 10%. And here are some of the most common topics discussed with the CF care team. Again, you'll notice that a lot of them fall below 50%. And something to note here is that only 80% of males with CF have ever discussed any SRH topic, meaning 20% never has. So this is our study aim. We aim to identify the male sexual and reproductive health topics that are important to key patient, family, and provider partners in the CF community. We aim to do that using a concept mapping methodology. Concept mapping is a community-based participatory research method that relies on the principle that community members are experts in their own lives. Down in this graphic, you'll see the main steps of the concept mapping methodology. First, we have brainstorming, which is pretty self-explanatory. Participants were asked to respond to the prompt, list all of the important sexual and reproductive health care topics for adolescent and adult males with cystic fibrosis. The second step is sorting and rating, in which participants were asked to sort the brainstorm statements into groups that were intuitive to them, and then they were further asked to rate the importance of each step. The third step is interpretation and analysis. The research team performed a quantitative analysis of participant data, and then a subgroup of participants attended an online Zoom meeting to analyze study findings and identify key patient-centered outcomes. All of these steps were completed via online on the Group Wisdom platform. So a little bit about our recruitment. Our inclusion criteria included males with CF age 18 years and older, adult family members or partners of males with CF, pediatric and adult multidisciplinary CF care providers, and male SRH providers. Our only exclusion was the inability to read or speak English. This is a limitation of the Group Wisdom software, which did not allow for language translation at the time. A little bit more about our recruitment. We recruited a convenient sample of participants in person and remotely. Remotely, we used the CF Foundation Community Voice listserv. We also used the CF Provider-specific listserv. In-person recruitment was completed at the UPMC Adult and Pediatric CF Center. Participants were compensated for each activity in the study, $20 for brainstorming, $20 for sorting and rating, and $50 for attending the interpretation meeting. This was provided via an Amazon online gift card. So here are the results for our first step brainstorming. Again, here is our prompt. We had a total of 89 participants complete the brainstorming step, 42 providers, 32 males with CF, 9 partners, and 6 parents. The average age of males with CF for this step was about 40 years old, with the range being 22 to 64 years old. In all, these participants generated 406 unique statements, which is a whole bunch. The study team then compiled this into 125 statements by removing duplicate and unclear ideas. For the second step, sorting and rating, we had a total of 69 participants complete the sorting step. Again, these participants were asked to sort the statements into groups or clusters that made sense to them, with the only rules being that ideas could not be placed into multiple groups, and each group must have at least more than one idea. A total of 65 participants completed the rating step. Each participant was asked to rate each SRH statement based on importance for addressing in the CF care setting for adolescent and adult males with CF, using a 5-point Likert scale, from 1, very unimportant, to 5, very important. And our last activity was the interpretation meeting. We had a total of 20 participants attend the online Zoom meeting. During this session, through discussion and consensus, participants generated novel cluster names and identified representative statements to them, outlier statements, and identified key patient-centered outcomes from each cluster. We're now going to kind of transition to the visual aids of the concept mapping methodology. So here you will see what is referred to as a point map. Each brainstorm statement is represented by an individual point on this map. So like I said, there was 125 statements at the end of our refinement, so there are 125 dots here. The clustering of them, you'll notice that the distance between points represents the frequency at which statements were sorted together by participants. Here's a close-up view of that point map, and here's some examples of statements. So over here you'll see statement 47 in the top right-hand corner, states family planning and CF clinic and access to infertility resources. Over here on the top left-hand corner, you'll see statement 94 states psychosocial planning and decision-making related to parenting, for example, finances, division of labor for childcare, or social support. This is the next visual aid that is provided by the Group Wisdom software. Group Wisdom uses this as a cluster map based on similar sorting patterns between the statements. So you'll see that these are all the same original points you saw before, the only difference being that now there are kind of bubbles grouping together specific statements that were sorted together. So like I stated during the interpretation meeting, participants met to create novel names for each of these clusters. So you'll see those here. Cluster 1 in the red, titled Family Building and Fertility. Cluster 2, the lime green, Psychosocial Aspects of SRH. Number 3, Being a Parent or Partner as a Male with CF. Cluster 4, Sexual Development, Function, and Treatments. Cluster 5, SRH Education, Communication, and Awareness. And lastly, Cluster 6, SRH Risks, Comorbidities, and Aging. And here you can see the average importance ratings by each cluster. Cluster 1 with an average rating of 4.06, Cluster 2 with an average rating of 3.84, Cluster 3, 3.95, Cluster 4, 3.73, Cluster 5, 3.94, and lastly, Cluster 6, 3.54. And again, that was on a scale of 1 to 5. So something we were also interested in learning about was, after analyzing this data, we wanted to know if patients, parents, partners, and providers viewed these topics as differing in importance. So here we utilize t-tests to create these pattern match graphs. You'll see here on the left-hand side is represented by males with CF, and on the right-hand side you will see CF providers. The distinction between this two group was the largest at our comparison. So as you go down this graph, you'll see each of the cluster names are listed and where they fall in importance. Males with CF had an average rating of importance of 3.87, and with CF providers being significantly higher at 4.37. Here we have a comparison between males with CF and the parents of males with CF. So again, same type of graph you'll see as you go down the order in which each cluster was rated. And the upward and downward trending lines show you the comparison between these two groups. The average importance again for males with CF was 3.87, and family members of males with CF was 4. Males with CF and their partners rated these clusters most similarly. In terms of order, you'll see that they aligned the most similarly. In terms of important, males with CF rated these as 3.87 again, and partners of males with CF as 3.99. So here are some conclusions. This is the first study to use concept mapping methodology to understand the topic of male sexual and reproductive health in CF. This work is critical as the CF population ages and will serve as the basis for development and improvement in SRH care provision. And these study results will be utilized to develop innovative patient, provider, and system-level strategies to integrate male SRH topics into routine CF care. Here's a thank you, and there's my email.
The next presentation is on current suicidality assessment practices and trends in reported death by suicide at US CF centers. Dr. Anna Georgiopoulos is Associate Professor of Psychiatry at Harvard Medical School, a child and adolescent adult consultant liaison psychiatrist, and has been integrated into the Massachusetts General Hospital since 2005. Dr. Georgiopoulos is an inaugural chair of the CF Foundation's Prioritizing Research and Mental Health Working Group, chairs the Education and Training Subgroup of the CF Foundation Mental Health Advisory Committee, and is a member of the CF Foundation's Sexual Health, Reproduction, and Gender Research Working Group. She also serves as U.S. liaison to the European CF Society's Mental Health in the Era of CFTR Modulators Working Group. She is recipient of the Carolyn C. Richard Mattingly Leadership in Mental Health Care Award from the CF Foundation. Her clinical research focuses to investigate the psychiatric complications of CF and its treatments, and to develop systems of care to improve the physical and emotional wellness of people with CF throughout the lifespan, and lead studies in CF mental health and palliative care. Thank you, Dr.
You took a breath. I was going to say that's probably plenty, but anyway. Okay, so today I am going to present some data on current suicidality assessment practices and trends in reported death by suicide at US CF centers. And this is the disclaimer and my disclosures. And this work was supported by a leadership and design grant from the CF Foundation, and we would like to thank the Foundation for use of registry data to conduct this study, as well as everyone who contributes to the CF Foundation Patient Registry. So this leadership and design grant is called Preparing the CF Foundation Patient Registry for Mental Health Research. And the context is that there will be a major update of the platform of the CF Foundation Patient Registry in the coming years, and we want to be ahead of the game to think about what additional mental health fields and data should be part of that update. In this project, I work with Alexandra Quittner, Beth Smith, Michael Schechter, who I think is here today, and Wendy Herr, and along with our research team and a wonderful advisory board of CF community members, including 3 adults with CF, Ed Kanda, Katie Kirby, and Laura Tillman, and 2 parents of children with CF, Ginger Birnbaum and Tanya Hamilton. And again, the goal is to support, how can we support longitudinal CF mental health research in a feasible way, without overwhelming all of us that are collecting data for the registry, but to capture mental health screening, intervention, and outcome. So one of the sub-aims of this study was to determine which variables should be included in this next large update of the registry database, what's the optimal frequency of data entry, and to assess the data landscape to consider how to implement research among younger age groups. So we're thinking about things like, should PHQ-9 depression and anxiety scores be in the registry? They're not currently in the registry, contrary to sometimes popular belief. Mental health intervention, should other comorbidities like we heard about from Alexandra be in the registry, and should there be any data about the mental health of children under the age of 12? So we have a variety of presentations arising from this project at this meeting. So take a look at poster 550, where we're looking at the data about children under the age of 12, poster 553, and Beth Smith's rapid fire presentation, looking at total versus item level scores and how it might be different to think about just having a total score, having all of the item level scores in the registry. And of course, we just heard about GEM-CF, and you saw that little snippet of data on comorbidities as well. Okay, so the background to this piece of the work about suicidality assessment practices is, as I said, in the registry, we have whether someone was screened for depression or anxiety, we have whether there's a clinical diagnosis recorded for depression or anxiety, but we don't actually have the screening scores. And so we surveyed USCF centers and examined the screening practices, and again, here I'm going to present the data pertaining to suicidality and self-harm. So we sent out a REDCap survey in March of 2023 looking at mental health screening, assessment, and data management practices to center directors, the social work listserv, the CF Psych listserv, which if you're not on that, please get on that listserv. mentalhealth@cff.org is how you can get yourself set up there if you don't know how to do that, or look at my.cff to do that. And also the mental health peer supervision groups, which again, if you're not part of a peer supervision group and you would like to be, mentalhealth@cff.org is a good way to find out more about that. So we sent out this survey, and then we also compared what we learned there to registry data from the last 12 years that was available from 2010 to 2022, looking at depression and anxiety disorders as complications, and looking at the deaths of people with CF due to suicide, trauma, or drug overdose. So these are the participant characteristics from our survey. We had 100 different CF centers respond, and mostly the responses were from mental health coordinators, social workers, and psychologists. We had a good balance of people who've been working in CF for a long time and people who were newer to CF. We had a good balance of pediatric, adult, or combined programs. A good geographic balance, and a good balance of smaller and larger centers as well. So one thing we learned, which was that people are doing a really good job of screening adults for depression using the PHQ-9. So of the 97 respondents who said they provide any care to adults, 98% were screening for depression using the PHQ-9. So sounds like that's going to be feasible to think about including, right? Only 2% were not doing that. There were no differences when we analyzed by all of those different participant characteristics that we just talked about: region, center size, years of CF healthcare experience. But of those who screened adults, only 58% were reported that they were systematically tracking the response to question 9, that suicidality item on the PHQ-9. And but everyone who was tracking the response to question 9 was also using a standardized tool to assess suicide risk. And the data looks very similar in adolescents. Of the 71 centers that are treating any adolescents, ages 12 to 17, only 3% are not using the PHQ-9 or PHQ-A. PHQ-A is an adolescent version of the PHQ-9 that just changes a couple of items to acknowledge irritability in adolescents, can be a presenting symptom of depression very commonly, and context of school rather than work. So almost everyone was screening with PHQ-9 or PHQ-A. Of those, 61% were tracking the response to that question 9 about suicidality, and 54% were assessing with a standardized tool for suicide risk. And again, there were no differences by participant or center characteristics. Now, what about children under the age of 12 years? Well, we know the guidelines, the CF Foundation and European CF Society mental health guidelines didn't call for systematic screening of children under the age of 12. They do call for, if there's any clinical concern on the part of the child, the family, the clinical team, we should be doing assessment, we should be offering interventions. However, at the time, we didn't have the epidemiologic data to say that, to be able to make the case to do this, and also there were a lot of questions about what tools would be used, and so hence TIDES 2.0, which we'll be hearing more about over the course of this meeting. But we asked, we wanted to know which centers were doing this anyway, even though it's going above and beyond the guidelines. And of the 71 centers who are seeing any younger children, 19 or 27% are screening children under 12 for depression, and the data is going to look very similar for anxiety. But what you also see here is that what a wide variety of screening tools are used, and this reminds me of where we were with the mental health guidelines 10 years ago when we did a needs assessment survey in the US and Europe. And we asked, are you screening for depression and anxiety? What tools are you using? And there were like 43 different tools that people were using. And it's like, how are we going to do research? How are we going to train teams how to use these tools and how to respond if we aren't doing something consistent? I guess this makes sense, right? That the centers that are screening children under the age of 12 probably are better resourced, probably, are a little more sophisticated and in terms of the bandwidth that they have. So more of those are actually screening for suicide risk. If they are screening those kids, 74% are screening for suicide risk. And what tools are people using to do this? Well, we can see that across the age groups here, the Columbia Suicide Severity Rating Scale is the most commonly assessment tool used to assess suicide risk. The ASQ is used by the next chunk down, and then Safety Interview and the PSS-3. And this makes some sense because the Columbia is the tool that's suggested in the guidelines as a tool that could be used. And for those who aren't familiar with it, I wanted to show a slide with the Columbia Suicide Severity Rating Scale. You can actually get to a copy of this using these QR codes. But it's very simple. It's not meant that you have to have professional training at all. This is first responders are trained to use this. Teachers are trained to use this, right? Any of us can ask these questions. And we can remember these questions even if we don't have this tool in front of us. And these are kind of the things to ask if someone's expressing concern about suicide or self-harm. So the first questions are, have you wished you were dead or wish you could go to sleep and not wake up in the past month? Have you actually had any thoughts about killing yourself? If the answer is no, that's it, over. If the answer is yes, then have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? And planning, have you started to work out or have you worked out the details of how to kill yourself, and did you intend to carry out that plan? So once you have question 4 and 5 about intention and planning, that puts you in a high-risk category. That's where, maybe someone does need some further emergent assessment if you don't have the capability to do that yourself. And question 6, we always also ask as part of this, is there a history of suicidality? Because that does put someone in a higher risk group. So have you done anything, started to do anything, or prepared to do anything to end your life? And then if that was in the past 3 months, again, that's going to put you at higher risk. Okay, so that's our survey data. But as I said, we also wanted to look and see how does this correspond to what we already see in the registry that might be relevant. Well, one thing that we did was to look at the rate of reported clinical diagnosis of depression and anxiety disorder for people with CF ages 12 and above. And there are pretty clear definitions of how this should work in the registry, which is, if somebody is still in treatment, so if they're taking a medicine or they're in therapy, then we would still say, yes, you have this diagnosis. Just like if you had CF-related diabetes and your blood sugars are in good control, we don't say, well, then you don't have CF-related diabetes, right? But you could uncheck if someone is no longer in treatment. And this is why it's maybe, would be really useful to have that PHQ-9 GAD-7 data, because someone could have very low scores, but yet be in active treatment, and that's why their scores are low. And those are kind of different things that we might want to be following along with. And we see that over time, those scores have been, the rates of those diagnoses have been increasing somewhat over the last 12 years. Now, what about deaths by trauma, suicide, and drug overdose? So to orient you to this slide, the green is deaths by drug overdose, and this was a new category in 2018. So that's why you don't see any green on the other two time portions. So we have 2010 to 2013 on the left, we have 2014 to 2017 in the middle, and we have 2018 to 2022 on the right. And the blue are deaths by trauma, some of which may be suicide, some of which may be due to risky behavior, some of which maybe just accidents that have nothing to do with mental health, but we thought they were important to include here, and deaths that were reported as due to suicide, which are in orange. And we calculated the proportion of deaths by any cause. So of all the deaths in anyone with CF that are reported in the registry, what proportion were due to trauma, due to suicide, due to drug overdose. And for suicide here, you see that the rate in the first time period is 0.8%. In the second time period, it's 0.7%. And then in the third time period, it's 1.6%. So it's roughly doubled over that time frame. And again, meanwhile, we have also the new category of drug overdose, which is also concerning, right? 1.2% of deaths. And the other thing to note here is that so the rate of suicide doubled, but the rate of total deaths didn't drop by half, right? So, or the number of total deaths. So, yes, there are fewer deaths, presumably due to ETI and other treatments, various reasons that people may have been less likely to die in that time frame, but that doesn't really account for this change. Then we thought we would look at the trends in the US general population suicide rates. And this is the way the CDC reports it. These are age-adjusted rates. And you see that they had been fairly steadily increasing, but actually at the same time that the rates were doubling in CF, in the general population around the pandemic, the rates actually dropped for a while, and then they went back up. But they, we'll see where this goes after 2022, right? Does it level off, or is it going to continue to rise? But it's a different pattern. So in conclusion, the proportion of total CF deaths per year attributed to trauma and suicide remained stable from 2010 to 2017, and then roughly doubled from 2018 to 2022. The prevalence of depression and anxiety disorder in the US CF population also increased during this time period. And then by contrast, as you just saw, those age-adjusted suicide rates in the US general population increased very gradually. And I calculated here what they were over those same chunks of time. So overall, it's a very gradual increase. And by contrast, less than 2/3 of the CF centers that participated in our survey specifically tracked PHQ-9 suicidality or self-harm, or are using a standardized assessment tool for suicide risk in adolescents and adults. So these data support the importance of a systematic assessment of suicide risk and tracking this information in clinical settings. And I want to thank all of those who gave permission for us to acknowledge you by name for your participation in this survey. I know that these surveys take a lot of time, but they're actually critically important to being able to move mental health and CF forward. And I'd also like to thank all of those who participated anonymously.
Okay. The fifth presentation today is effects of adjusted ETI dosing on sleep behavior and physical symptoms in young children with cystic fibrosis. Dr. Arwen Marker is a pediatric psychologist and assistant professor at the University of Utah School of Medicine and Primary Children's Hospital in Salt Lake City. Dr. Marker earned her PhD in clinical child psychology from the University of Kansas, after which she completed a pediatric psychology internship at Nationwide Children's in Columbus and a fellowship in pediatric psychology at Intermountain Primary Children's Hospital in Salt Lake City. Dr. Marker has experience providing psychological services for children with chronic medical conditions and their families, including type 1 diabetes and cystic fibrosis. She joined the Pediatric CF Center at Primary Children's Hospital in 2022 and currently has a focus on improving screening efficiency and increasing understanding of psychological changes that may be associated with ETI. I'd like you to welcome.
Thank you. So I'm excited to be here talking to you all this morning. There we go. So I'm going to be talking about effects of adjusted ETI dosing on sleep behavior and physical symptoms, specifically in our very youngest group of kids who have just, recently in the last year and a half gotten access to these kinds of modulator or to this modulator medication. I didn't do a pretty acknowledgement slide at the end, so I'll do that now. Just wanted to thank, the rest of our primary children's CF team, including one of our nurse practitioners, our pharmacists, the rest of our mental health team, as well as my husband, who is not a part of the CF Center, but he is my lifelong stats consultant. So thank you to him for helping me make all the pretty figures for this. I am not cool enough to have any disclosures. So some background. I think we all know that the ETI was just approved for that very youngest group of kids, our 2 to 5 year olds, in spring of 2023. And overall, right, the initial clinical trials for these medications did not find any kind of mean significant changes in mental health outcomes, particularly in adults and adolescents. But they did identify, some common physical side effects, things like headaches, abdominal pain, rash, all of those things that, the doctor kind of talks through before you start this medication. However, despite, all of the really positive physical health improvements from taking ETI, a couple of things. One is we continue to see that rates of depression and anxiety in our adolescent and adult populations appear unchanged, right? Those have not vastly improved, even while physical outcomes have vastly improved. So why is that? We also have had some more recent studies and, kind of smaller studies, case studies come out that have identified some kind of adverse changes in depression, anxiety, behavior, sleep after starting ETI. So for example, one study or a couple of studies have found kind of acutely worsening depressive symptoms in young adults and adolescents, or some like acute onset of suicidal ideations, as well as I know that multiple of our other presenters today have kind of talked about some of the sleep deficits and difficulties in CF. So all of these things are things that I think we're still just trying to find out more information about. And our group, previously presented just a poster where we found from kind of baseline before starting ETI to like that initial 3-month, when we saw them back for their regular clinic follow-up visit, that both sleep onset and sleep maintenance got worse in this, these little toddlers who just started ETI. So in this study, or in this data analysis, I really wanted to look more closely at this data and kind of what's going on here, as well as add in the 6-month data. So my goal with this with this project is that just during regular clinic visits, we have been collecting data kind of starting before, like right before they start the medication, and then at 3, 6, 9, and 12 months. So today I'm going to be mainly talking about the 0 to 6 month data. So question 1, I wanted to know, do these symptoms, things like physical side effects, behavioral symptoms, sleep, do they change? Do they get better? Do they get worse? Do they not change after starting ETI? And 2, I think a really common practice that our doctors have been using is when kids are having these symptoms that they are making some adjustments to their dosing of their ETI medications. So what happens to these symptoms if they have adjusted dosing? So we recruited, not really recruited, we administered these measures just as part of standard clinical care for our patients. So starting, around April of 2023, we had all of our kids who were going to be starting ETI in this 1 to 6 age group at a large Mountain West Pediatric CF Center, complete surveys at baseline, so kind of right before they started the medication, 3 months and 6 months after starting. Patients were either categorized as being on full dosing or adjusted dosing. And adjusted dosing could include kind of flip or swap dosing, where you take the morning and evening doses and you switch them, or reduced dosing, where they actually reduced the amount of the medication that the patient's taking. And again, I got some help with doing some nice mixed modeling in R for this. The measures that we used were the pediatric symptom checklist. I actually used 2 different versions of this. So this is a 17-item measure that really, it's a parent report measure for these very young kids. Obviously, we're not asking 2-year-olds to answer a questionnaire. But it kind of measures a big variety of behavior things. So things like, is your kid having problems with like having tantrums or being aggressive? Are they having anxiety symptoms? Are they being irritable? So it kind of has a couple items that touch on a variety of different mental health areas. So we used the regular version for our kids 4 years and older, and then the preschool version for our kids 3 years and younger. We also administered the Pediatric Insomnia Severity Index. This is a really brief 6-item measure that measures sleep onset, so difficulties falling asleep, and sleep maintenance, difficulties staying asleep. And then we also asked just kind of a checklist of those really common physical side effects. So has your child been experiencing headaches, abdominal pain, or rashes? Never, sometimes, often, or always. Here are some of our baseline demographics. And I feel like the ends on this are a little, they look a little inflated because this is, all the data that we had at baseline, but not all of these kids completed their 3-month or 6-month follow-up. So the actual numbers of kids who are included that had, 0, 3, and 6 were closer to the 64 number. But you can see that on average, our kids were 3, almost 4 years old, 21% of them. So not a super small number, almost a quarter of our patients had that flipped or reduced dosing. You can see kind of the mean scores for the pediatric symptom checklist and the sleep measures. And then for those physical symptoms, we found that 16%, and this is the baseline data, so kind of before they started taking the medication, already 16% were experiencing headaches, 35% were experiencing abdominal pain, and 9% were experiencing rashes. So let me explain what's going on here. So these are spaghetti plots. So what these represent is I'm not sure how to use the mouse. In black in the middle, that is the mean, the average for everybody. Each individual line is an individual person. So you can kind of see, kind of all together that mean change in black in the middle, but you can also see, right, like there's a huge variety in terms of what people's responses were. So overall, on both versions of the pediatric symptom checklist, we found that the total scores did not change significantly over time, right? You can see that black line in the middle stays pretty steady from 0 to 3 to 6 months. And this is, the same thing, right, that they found in those initial clinical trials. But when we take a little bit of a closer look, we find some other kind of more interesting things. So this is comparing for the preschool version, so those kids 3 years and younger. Were there any interactions between getting the full dose of ETI versus those kids that had the dose adjustments? And we found, yes, there is an interaction between time and that dosing adjustment. So on the left-hand side, you can see that overall kids who kind of got the full dose and stayed on the full dose, their symptoms, kind of like overall behavioral symptoms, either went down a little bit or stayed about the same, versus on the right-hand side, you can see that those kids who did have dose adjustments, and this probably makes sense, right? The reason why they had dose adjustments is probably because they had worse behavior symptoms at 3 months. But then even with those dose adjustments, they kind of continue to be worse at that 6-month mark. In a mixed model of kind of what is driving these behavior change symptoms, we found that headaches, sleep maintenance, and this time dose adjustment interaction accounted for about 20% of the variance in these total behavior scores. So that means that kind of headaches, sleep maintenance, and these dosing adjustments are potential drivers for why these kids' behaviors are getting worse. I looked at the same thing for the older kids. However, we had very few kids in that 4 and older age group that had their doses adjusted. So it didn't feel like it was appropriate to actually run the stats on that. You can kind of see what it looks like. It looks kind of similar to the younger kids. That kids with those dosing adjustments are seeing behavioral symptoms getting worse over time. But again, right, there are so few of them that didn't feel good to look at. But we did still run the full mixed model to see like what symptoms are influencing these worsening behavior symptoms, and found that kids who are experiencing headaches, rashes, and sleep onset difficulties, that accounted for 37% of the variance in changes in total scores. So again, indicators that those may be symptoms that are kind of potentially driving that relationship, kind of driving why their behaviors are getting worse. And then 2 other things I wanted to pull out separately. One is we found that sleep onset varied significantly over time. So there was a main effect for sleep onset changing over time. And this interaction between, was that different between kids on the full dose versus kids on the adjusted dose, was trending but not significant. It was like P equals 0.07. And so you can see, again, in those spaghetti plots that for kids without adjustment, staying pretty stable. For kids that did have adjustment, their sleep got worse the first 3 months after they started the medication, and then their dosing was adjusted and it got better, but that wasn't significantly different. And then for headaches, kind of found a similar thing. So again, headaches significantly varied over time, and that dose, full dose versus dose adjustment interaction was just barely not significant. P equals 0.052. So for this data, this might be something that, hey, once we have our complete sample, once we have a bigger sample size, might be something that pops out. So in conclusion, one thing to highlight is that these changes in headaches and sleep onset were really common physical side effects in young children who started ETI, that toddler kind of kindergarten age group. And both of them trended towards being mitigated by ETI dose adjustments. So kind of like when kids started these medications, headache and sleep onset difficulties got worse, and if their ETI medication was adjusted, then they almost significantly got better. Another thing to note is looking at kind of comparing the baseline demographic data to what we found is we really didn't see we saw that young children with ETI dose adjustments for worsened behavioral symptoms actually had lower behavior scores at baseline. So suggesting that, these are not just kids who had a bunch of behavior problems at baseline and then they continued to have more behavior problems moving forward as they got older. This really suggests that there's something else going on there that, might have something to do with the medication. I feel like there's other points I wanted to make here. My mind just went blank. So for our young children with these worsened behavior symptoms, I think some things to really consider are some of these symptoms that we are definitely seeing, like the headaches, difficulties with sleep onset, are those things that are driving these behavior change, right? If you think of your, typical 3-year-old, are they going to be able to tell you that they're having headaches or they're not sleeping as well and that's why they're suddenly having more tantrums? Or are you just going to start to see that they're having a lot more tantrums or they're being a lot more anxious? And so I think really important for us to continue to look at how all of these things are interconnected and trying to tease out causality, which is obviously really hard. So I just wanted to have some references for you guys. I just wanted to say thank you so much to all of the patients at our CF Center who completed these measures and helped us to be able to look at this information.
Great, George.
Thank you for all of the wonderful talks today. As a reminder, please submit questions through the app if you have some, or we welcome you to ask them through the microphone. So we've got several questions, so I'll try to get through them all. One question about the GEMS, a couple of questions about further studies or future ideas about using it with children and adolescents.
That's a great question. I think for our first step, we thought it was really important to focus on adults, but I agree with that comment that the next logical step is to downwardly extend the same measurement process to adolescents, maybe school age and adolescent kids. And I think this will be tremendously helped by the TIDES 2.0 study, where we're going to begin to look at some of these behavioral issues, depression, anxiety, as well as behavior. And in 18 months through 11 years, that will give us some idea of some of those mental health comorbidities in younger age group, and then think about downwardly extending that GEMS to adolescents and school age children. I think that would be great.
Great. This question is for Kelly. Previous surveys of CF adolescents have found that many see their CF care team as primary care. So how could sexual reproductive health be better integrated by non-primary care providers by the CF team?
Yeah, great question. I think just, having the idea of identifying important concepts valued by patients and their family members and kind of just making that routinely addressed in CF care settings is a great place to start.
And a follow-up for that, did any of your data suggest, the timing of when would be the best time to bring some of these topics up?
Unfortunately, this study did not really ask about timing of when to bring these things up. And we did not also ask the importance compared, for an adolescent population and an adult population. That's something that I would be interested in to know in the future.
Yeah, great, thank you. So I believe this will probably be for Anna. We recently had a patient ask for his depression to be taken off of his diagnosis list as he has not experienced symptoms in many years. I actually had this happen to me as well. What are your thoughts on this and its presence, keeping it on the list as possibly a precursor to possible future self-harm or suicidality? Is this important to continue to keep on our patient diagnosis list?
Yeah, it's a complicated topic, right? As far as the registry is concerned, if the person's still in treatment, then, it's still a complication of CF. Here in Boston, like everybody's in therapy, so that means every single person, is going to have the complication, right? But there are other factors that come to mind, right, for insurance reasons, things like that. Maybe that's less important in a CF population where there are already maybe barriers to, pre-existing conditions, but people can have lots of different reasons that matters. I think it's a conversation with someone. What is it about, the way that they see themselves perceived, or are they feeling like they're being treated differently, or there's stigma, from other specialists or in other settings, and is there a way to intervene with that?
Great. Okay. A couple of questions about kind of thoughts or ideas about why suicide ideation attempts proportions are increasing faster than the general population, and kind of why, just kind of thoughts about why we think we saw that double increase there in some of those statistics that you provided. Any?
Well, that's a really good question. I mean, the other one of the factors that changed at that time is the introduction of ETI being available to a large proportion of the population. There certainly have been case reports, and there's some newer data just coming out in the literature now, looking at some other registries that are seeing signals for suicidality around the time of introduction of ETI. So that may be one reason. It could be that it's also being recognized more clearly, right? I think we all know about situations where someone died and it's kind of like a soft call suicide, right? Like maybe they stopped taking care of themselves, or so in some senses maybe tip of the iceberg of people who are kind of self-neglecting and so on. But maybe people within the CF community are more likely to be able to understand something that happened as a suicide and for that death to be categorized in that way. Perhaps that could be different than the general population. Mm-hmm. Although we also see that over the pandemic, the stigma was lessening and people were more likely to talk about mental health and suicide. And again, that may have resulted in a decline in the suicide rate in the general population.
Yeah, there was a couple of comments on, what impact did COVID have on those rates, which I think we all question. And then also is part of, why we're seeing that increase in rates, because we are doing a better job with talking and assessing of those things as well. For the GEMS measure, did the age of diagnosis with CF factor in? Was there any difference between those diagnoses as a newborn versus teen versus adult? Was that captured in any way in your measure development?
That is just an excellent question. And I would have to say yes. We have not dug down deep into the data about that. But one of the things both Dr. Smith and I noticed in doing the 60 interviews is those who had a late diagnosis, often misunderstood, misdiagnosed with other conditions, often seeking help but not getting it, had really some very severe mental health comorbidities and trauma as a result of that. And so it would be, I think, another analysis that we would love to do is to look at that, whether you were diagnosed via newborn screen and therefore treated immediately, right, cared for as an infant, versus, that seemed to appear much more often in minority groups that we were assessing, where you don't have newborn screen available or the panels that are being utilized do not contain all the right variants. And so we did see a vulnerability in those who are late diagnoses. And so we'd like to go back. I mean, we haven't been able to analyze that quite yet, but we have information about that. And I think that is such an important point. When we see the impact of newborn screen, it has so many positive cascading benefits over time that you are treating someone immediately, they're getting better right away, and you don't have this confusion and ambiguity about what's wrong with me. And that led to an awful lot of trauma in this population.
For Dr. Marker, when did the ETI dosing change in your study? Was it between that baseline and 3 months or after 3 months?
Yeah, like when did the adjustment happen?
When did the adjustment happen with your results?
Yeah, so that's one of the things that is also a little, I think all of the data I presented is lovely, messy clinical data since we collected it, just in clinic. So the dosing adjustments happened at a variety of times for those patients, which is why, so they're all kind of lumped together now. Some families even started with an adjusted dosing because they were nervous about sleep or behavior effects. I think the most common time was sometime in that like 1 to 3 month mark. And then, some people, they like adjusted and then went back. So all of those are things that we need to look at in more detail. But yeah, so there's kind of a variety of different ways that people had adjusted dosing.
And just to clarify, was the dose adjustment due to the behavioral changes, or were there other factors like LFTs or other things going on?
I think in the vast majority of cases, it was because of some sort of side effect in terms of behavior, sleep, headaches, abdominal pain. Like one of the symptoms that we measured, in very few cases was it due to LFTs.
And can you comment on, the 2 to 5 year old range is a time of profound growth and behavioral challenges. How does your center kind of differentiate between, we need to make a dose change, or this is kind of normal toddler preschool behavior?
Absolutely.
Can you comment more on that?
Yeah. And I think that's another issue with the data is like, how do you know, is this from the medication or they just got older and they developed those like terrible 3 behaviors? And it's really, really, I don't think we really can differentiate that right now. I think a lot of the dose adjustments are family driven. So families who kind of feel very strongly that, hey, I feel like this is an acute change, or this, got worse after they started the medication. I think our center is pretty liberal with making those dosing adjustments. So if a family thinks that it would be beneficial for them to adjust the dosing, our center is like, yeah, let's try it. And then if all of the behaviors are still there 3 months from now, then maybe that gives us more evidence that it wasn't the medication. So I think they are just kind of taking the family's preferences into account a lot.
I'd just like to really comment on the strength of your study using the pediatric symptom checklist. There are normative data. So what's nice about that measure is that you can actually take your means and standard deviations, see what proportion of your children may be outside of the normal range. So that's an advantage of using this standardized measure that you used. And as we move forward toward TIDES 2.0, we're going to be comparing to a standard diagnostic measure. It's going to be the BASC-3. We'll be comparing brief, standardized checklists like the pediatric symptom checklist and the PROMIS measures, which are much shorter and briefer than the long BASC. But that is a huge advantage, is to have normative data, and then you can look at your sample in relation to the norms.
Similar to that, did you look at, Dr. Marker, did you look at any of the specific items on the pediatric symptom checklist? Because there was some curiosity of what maybe changes you had seen on those.
Yes, I think that's a really important next step that we haven't looked at yet, but that we definitely plan on looking at. So we're in the process of completing the 9 and 12 month data collection. And I think one of the hard things about the pediatric symptom checklist is that it just kind of smushes all of those symptoms together. So if there's a subset of kids that are having lots of tantrums and aggressive behaviors and a subset of kids that are having anxiety problems, right, like that total score isn't really capturing it as well. And only the older kid version has the breakdowns into internalizing, externalizing attention symptoms. So I definitely would like to do more of an item analysis in the future.
Great. This is kind of combining a few thoughts from the presentations. Are there any anecdotal accounts or any information about increased mental health issues such as acute onset depression, auditory hallucinations for patients on ETIs, and use of cannabis products. So for the example that was given, the patient has been on ETIs for longer than 18 months, came to clinic and scored very high on the PHQ with positive score for question 9, endorsed intent, no plan, but was hospitalized and stated that this patient was smoking marijuana about twice a week. Curious if there's any correlations or anything that you have seen with ETI and marijuana use.
Anecdotally, with my patients, no, I haven't seen that in the data that's reported yet. No, so I guess I would just say that kind of experience, if all of us report those, would help bolster a little bit more evidence to go back on, or having more substance use screening, like in GEMS or things of the sort, could help us identify and connect those issues in the future.
Yeah, I would say we don't have that data in CF, but psychosis is a known risk with cannabis use. Typically, in practice, it wouldn't always be someone who's using it twice a week that you would expect. You might expect heavier use, but there are always those people who use something once and it just doesn't agree with them, right? So especially if someone does have some family history of bipolar disorder or psychosis, if they have other risk factors for psychosis, sometimes people do get unlucky and have a not very good reaction. The other thing is that, over time, depression is a risk as well in longitudinal studies of cannabis use, right? So kind of like you think about alcohol, right? People who have social anxiety might feel a lot better when they use some alcohol and go to a party, right? It's easier to talk to people and all of that, but actually, then they're at risk for alcohol dependence. They're actually at higher risk than the general population, and you may see anxiety increase over time and depression increase over time. So that's, as we're talking to people about cannabis use, we want to kind of think about that risk-benefit ratio, and also kind of dose-wise, right? Some people might find, like, on a low dose, maybe their anxiety is a little better, and at a higher dose, their anxiety shoots through the roof. And that we see with people with CF for sure.
Good.
That was great, Anna, and I agree. I think the only other thing that I'd add is, in those situations, I think it's really important to ask how they're using cannabis. So if they're using something that has like these super high THC concentrations, like dabbing, vape pens, that kind of stuff, that's when you're going to see those real increased risks, even with one-time use. Some of the studies around marijuana use and onset of schizophrenia and some of these auditory visual hallucinations are wild. And I think we as pediatricians, but also as healthcare providers generally, need to catch up and need to be asking about this. So I think that's why a big theme of all of this is we probably have to talk to people a little bit more.
Right. I mean, yeah, exactly. I mean, there are hundreds of compounds in cannabis, right? So as we think about, medical use that's been legislated, that's really different than medical use that's like someone's purified a compound and tested it and gone through FDA studies and knows what dose to prescribe and what those risks are. So, when people kind of think about, I want to do something naturally, not all anything that can have a psychoactive effect for good can also have one for bad.
Okay. Let me see here. Should we, on the GEMS, differentiate cannabis for recreation versus managing CF symptoms?
That's also a really good question. So one of the things in terms of using GEMS is that, imagine it'll take less than a couple minutes to tick off sort of whether you have yes or no, these kinds of issues. And then what we really see that the mental health coordinator can then look across this and maybe 3 things are endorsed. And that's really could stimulate that conversation that we were just talking about. Because right now that's all flying under the radar and it's not discussed. I mean, in our clinic, I think we're really open about it. And so we get more information from our adults with CF. But I think the beauty of the GEMS is that it allows you to then open that conversation and find out, how are you using marijuana? Are you smoking it? I mean, so in my clinic, for example, I have to say, we do have people who are using cannabis, and it's often for the reasons you described, getting to sleep or pain. And we always talk to them about how they're using it. Are you smoking it? And then we encourage, medical marijuana is legal in my state, we encourage them to use gummy bears or something and not to use, not to smoke it and not to vape it. So having that conversation then allows you to begin to address it, and you can find out if it's chronic. Is it twice a week or is it every day? And you can begin to then think about whether there's some sort of intervention that might be needed.
Great. One of our social workers and researchers from Australia wanted to know about the elevated ADHD rates in CF. Any insights into the reason for this?
Well, I think this is really one of the most interesting questions, right? We do think, and I'm going to let Anna speak to this as well because she did a retrospective study, but the studies do show, and they're small, they're single center, but do show people with CF tend to have higher rates of ADHD, even as children and as adults. And so one of the things that was really prominent in the GEMS interviews was people struggling their whole lives with it, but no one actually sending them for a formal assessment, and they're never getting any treatment for it, that they just continued to struggle on. And that's not really helpful because if you really have ADHD, we do have really good interventions, both medical interventions, behavioral interventions, but we're missing a lot of people. And so lots of these people said, oh yeah, I had ADHD, but we couldn't get an assessment, blah, blah, blah. And so it was never formally diagnosed.
Sure. I mean, what the literature shows when, first of all, there are differences. If you look retrospectively at rates of diagnosis, then we don't know if those are actually the rates, right? Again, those may be kind of tip of the iceberg. But when you look at studies that screen prospectively, you do see in adults with CF rates that are 3 or 4 times the rate you would expect in the general population. And even in pretty rigorous studies using a variety of methodologies, you definitely see elevated rates in kids as well. And the other thing that's kind of interesting is you don't see the male predominance that you expect to see in ADHD. We see that it's more even in CF. So we think, there's probably something else going on there, which could be a cohort effect to some extent, right? People who were diagnosed before newborn diagnosis with failure to thrive. We know malnutrition is a risk factor for ADHD. Advanced lung disease, right, with poor oxygenation, that may be a risk factor. All the burden of CF and all the treatments you have to do, right? So you may have some ADHD symptoms, but now if you've got 2 or 3 hours a day more stuff to do, it may become more impairing than it otherwise would. And so that could be a factor as well. One of the things, though, to think about with that GEMS data is that was, as you pointed out, that was a highly enriched, diverse sample of people who may be at higher risk for mental health conditions, which is why it's so important that we be able to do some of that, the national validation study to see what are actually these rates in the general CF population and how close do they come to this group of folks who endorsed, 6 or more of these comorbidities with really tough combinations of experiences.
For ETI in children 6 and younger, was there a component of your research that looked at behavioral changes if the ETI was completely stopped instead of dosing changed?
That's a great question. I believe that often, given that these kind of the timing of these data, that, we do have a subset of patients that have never started ETI because they are nervous about side effects or things like that. But most of, I don't think we had any in this sample in that 6-month time frame who decided to stop the medication. Once we have the 1-year data, that I'm guessing will be a variable that will be in there because most of the time, once they've started, they're really trying to stay on it as much as they can. So often our providers are trying some sort of, flip dosing maybe first and then a reduction next and then stopping the medication. So within that 6-month mark, there really just weren't any of those kids yet.
Has it been looked at in terms of ETI ineligibility in cases of suicide after 2019? Do we have any data on that?
Like, in other words, whether there were differences were people who were ineligible more likely to have died by suicide, right, or people who were eligible.
Did we look at?
Yeah, we have not looked at that, and that would be a really interesting analysis to do, right? Is to look at
Yeah.
who are those folks. And that, again, if we have more mental health data in the registry, it'll be easier to do those kinds of things, but it could be looked at in that way.
Absolutely. Have you assessed GEMS for measurement and variance across intersectional identities?
At this point, the data that this is sort of the top line. Can you explain more about what that,
I don't know if who asked the question is here, if I had more information, but I'm assuming just when we have intersectionality in our identities, have you looked at kind of GEMS and how that might impact?
Higher rates.
So they're higher?
Higher rates of symptoms and people have more than one minoritized.
Oh,
I
that's
believe, yeah.
okay. That's interesting.
Yeah.
So we have not done that where we've looked at whether they may be African American and LGBTQI plus. Is that what you mean? Yeah, multiple different kinds of identities. We have not done that data analysis. But again, I think that would be really interesting. We did have a very enriched vulnerable sample. One of the things that we really observed in recruiting a lot of minorities, a lot of people living below the poverty line, federal poverty guidelines, these people were really very open about their struggles, but were having struggles on many, many dimensions. So that would be interesting to look at whether, there is a difference in how many comorbidities they endorse if they have more than one kind of difference.
Great. And then this is for everyone on the panel, asking about our preferred screening tools for patients under age 12. I'm assuming for anxiety, depression, the things that we have talked about currently. So, anyone?
This is like the question of the day, right? I think this is a wonderful question. We want to know the answer too. I think we really need the TIDES 2.0 study. This is a very rigorous study that we're planning with incredibly complex but good sampling techniques that will remove bias. And we really want to test 2 brief screeners. So the pediatric symptom checklist is one candidate that we're going to use. And there's a preschool version, as you heard today, and it goes all the way up, past school age. And there's a child report version that begins at around age 6. And so that's one of the measures we think may be a candidate. And they're good normative data. There are great thousands of kids, normative kinds of data that you can look at by gender, by age. The promise measures are also wonderful. And those were developed, both of these sets of measures were developed with the very best measurement principles. The promise measures, both of these sets of measures are free. That's another criteria that we believe is very important. And the success of PHQ-9 GAD7, they're free, they're translated into many world languages. And so this is sort of the model we want to follow. So we're going to compare the promise and their, measures of sleep and depression and behavioral things in the promise measures, as well as in the pediatric symptom checklist. So we want to have them compete against the BASC, which is the diagnostic criterion. So that's like a parent report with over 130 items. So we're only going to do that at time 1, but it will give us that diagnostic rigor to then see which of those really brief screeners is best in terms of sensitivity, specificity, and picking up those kinds of behaviors we're interested in. And so it's hard to answer right at this moment. In my own clinic, I'm using the pediatric symptom checklist. I know Dr. Emily Muther is using it as well. It's just been very easy to use it, get it, and it has great normative data. We do see elevations in our little kids on ETI in terms of inattention, externalizing behaviors, irritability. So we're seeing scores that for some percent of our kids, they're clinically elevated. So right now, I wish I could recommend, but I think it would be useful to consider using, for now, the pediatric symptom checklist or some of these promise modules. I think it's very important to begin to pay attention to those side effects and do something about them.
Yeah, I'm an adult pulmonologist. I'm just going to pass it around.
I know in my clinic, I use the pediatric symptom checklist and the promise measures as well.
Yeah, agreed with everything Alexandra said.
Yeah, I just wanted to echo the importance of doing the study to compare and figure out which one is the best one, because I know our clinic has been considering starting to use we're already using the PSC for those little teeny tinies, but for the 6 to 11 age group, that we were like, well, the promise is shorter, but like, does that mean, like, should that be the reason why we're picking a measure over another one?
And with the promise, you have to use several modules, so it's
Yeah.
not clear,
How short it will actually be in relation to the PSC, right? Because there are different modules that you pick. So it is really short, and there are child versions and parent versions, so that's another advantage.
Yeah, and one of the other things to emphasize, which I think you've said at some point, but as we were talking about ADHD, there is a cognitive module for Promise, and the PSC also has an inattentive subscale, right? So there's kind of internalizing, externalizing, and inattentive. So for kids, we think it's important to be picking up on these inattention or kind of more behavioral disruptive symptoms, as well as depression and anxiety. But we'll see how the data fall out after the TIDE study.
And are we sharing the GEMS CF screening tool at this point, or we're waiting for future validation?
That's a really good question. So we are doing, as soon as we get home from NACFC, we are launching phase 3. So we will be sending out the one I showed you that's revised and iterated and tested, along with some convergent validity measures to 60 adults with CF. And then I think it would be great to get in touch with us because we did put our grant in to validate it on 250 adults, but it might be possible that we would allow people to use this first iteration and maybe share back the data, because I always find that that's very useful as we're developing a measure. We know that we'll hear maybe about our grant in November and get started in January, we're hoping. But it takes a while. And so, yes, I think we will try to make it available and kind of make that agreement. Could you share back your data so that we can learn more about the instrument?
And can you clarify real quick on, in your study, when you did, talked about cognitive testing, there was questions about what you meant by that step.
So cognitive debriefing interviews are a part of developing an instrument. It's part of the COSMIN. It's part of the PRO FDA guidance. So what you do is, with a very different sample than you elicited the mental health concerns, you pick a new sample and you bring them the draft screener with the items. And for every item you say, what were you thinking about? What made you give it a 3 rather than a 4? Are the instructions clear? Are the rating scales easy to use? By the way, people love the 4-point rating scale. And we debated, people love 5-point, but then people end up choosing the middle. So they loved the 4-point. They found easy, quick, very doable in a clinic setting. And so really that is, that's the path that we have to follow.
And just two more, a little bit about the registry, but can you clarify by what you meant by the PHQ-9 question 9 tracking? How is that differentiated? Centers that were tracking question 9, those that weren't?
Yeah, thank you, because
clarification.
that is something that I should have explained. So how we defined tracking in the survey was that there was some sort of systematic way that you were keeping track of the answers, right? So it could be that it's in, that it's in your EMR, your electronic record, but that would mean that it's there in a consistent way for every person who's getting that screening tool, where you could go find it and pull it. Part of why we're interested in that is that we're thinking about different ways with the registry, right? Can there be some data pulls directly from the EMR? Would it be, how are people gathering this? How hard is this going to be to translate from clinical care into registry data? So it doesn't mean like you're looking at the score or you're thinking about the score. It means you're keeping track of that in some sort of a database, in an Excel or in REDCap or in your EMR in a way that is systematic and could be pulled for data use. But for quality improvement, what some centers do, right, is they look at that specifically. Hey, these are our folks who've ever had an elevated question 9. So maybe we need to be paying more attention to their mental health. Do they need to be screened more often? Do we at least want to make sure we're checking in between, so how are we managing that risk in the population? So that's why we thought it was important to share this data. Could we be doing a better job and a more thorough job of making sure, that people aren't falling through the cracks?
And just one more question, more about the registry, if you want to comment on this one. If a patient is not in mental health treatment and does not have a clinical diagnosis of anxiety or depression, but they screen very high on the PHQ-9 or GAD-7, treatment is recommended, how should this be recorded in terms of the anxiety, depression in the registry?
Well, so if they don't have that diagnosis, to me, that means no one's done an assessment and an evaluation and made a diagnosis. So that person needs some sort of an assessment. And the assessment could be on the part of the team, the social worker, psychologist, pulmonologist. It could be this person has depression and is choosing not to engage in treatment, right? So what it doesn't mean is the score is high, therefore I check this box of you have depression. But there's this missing link there of the assessment and the clinical judgment. It doesn't have to be that a psychiatrist is the one that makes that diagnosis. Primary care doctors make diagnoses of depression and anxiety. Psychologists do that. Pulmonologists can do that, right? And so it doesn't specify how that diagnosis was made. That's another interesting question: is should it be specifying? Can it be patient self-report, right? That I was diagnosed elsewhere. I have this diagnosis. It probably should be in the registry. If they say I see someone outside and I've been diagnosed, then that should be tracked, right? But this is one reason it's, I think, important to have those scores, because then we can kind of look at the interaction between those pieces.
Is there any more questions? Anyone else? Questions, comments for our speakers today? Okay, well, we like to thank you all for being here and for the lively discussion. Thank you.